Good morning, good morning. Good morning. And we need 1 million more midwives. I'm just going to wait a little bit for the last participants to come. Warm welcome to the 4th day of the ICM Triennial Congress 2026. I'm still full of energy. I hope you too. And it's absolutely incredible what has been going on and what is going on. I think many of our brains are buzzing with new knowledge, new experiences, friendships, conversations. Some of us have sore throats from presenting and speaking a lot. And we are going to have a very exciting closing ceremony at 4 o'clock today. And I hope to see you all there too. Before we start, I really want to say that ICM values knowledge, traditional practices, community leadership, and ancestral ways of caring that have supported women, newborns, and adolescents through generations. ICM recognizes and acknowledges the concern and the frustration expressed by midwives from indigenous communities and their supporters. We are listening. Thank you for bringing up difficult and complex conversations into this space. And we take these discussions forward as we work towards a revised position statement, which we commit to present at Council 2027. Thank you for that. Now into the plenary session of the 4th day. And this is very exciting. We are going to talk about innovations and how midwives have been innovating from the beginning of time, leading up to where we are today. We are part of the solutions. I'm really pleased to introduce our keynote speaker, Hege Ersdal, Professor in Simulation and Global Health at Stavanger University in Norway. Dear Hege, please join me on stage.
Thank you so much, Anna. It's an honor for me to be here and share with you how midwives have contributed as innovators across time and culture in the Safer Births Bundle of Care project. As you are very well aware, in large part of the world, the day of birth is the most dangerous day in one's life. Today, 6,000 newborns will die on their first and only day. 800 mothers will die because of complications related to childbirth, today and every day. The majority of these deaths happen in low and middle income countries, and they are preventable with good, basic, but time-critical care. Again, as you know, babies die because they are born asphyxiated and not able to start breathing on their own. This little boy will die within minutes unless the present midwife starts effective ventilation quickly. Young, healthy women bleed to death with anxious midwives around who don't know what to do, while they are waiting for a doctor who may never come. With this background, 15 years ago, the American Academy of Pediatrics developed the Helping Babies Breathe course to help train midwives in the basic life-saving steps of newborn resuscitation, focusing on the effective ventilation within the first golden minute after birth. As you can see, the course materials are visual and intuitive, with much time allocated to practical hands-on training. The training tools are easy to carry on, they are low cost, and they can be left behind in a facility to allow for refresher training, but also for scalability. Based on the initial success of Helping Babies Breathe, a similar course for helping mothers survive bleeding after birth was developed by JPEGO with partners to address the leading causes of maternal death, postpartum bleeding. And again, the simulation training focused on only the most essential life-saving steps, basic steps to be done by the midwives. And I must say that your great leader, the boss, Anna, she has worked a lot with this course over the years. In 2010, we started the Safer Births Innovation and Research Project at Haydom Lutheran Hospital in rural Tanzania by testing the effectiveness of the Helping Babies Breathe and the Helping Mothers Survive programs. We did what was usual at the time. We provided a one-day Helping Babies Breathe course. We tested the midwives with simulations before the one-day course and 7 months after the course. And their simulated skills improved from 40% correct resuscitation before the course to 80% correct. Yeah, we were also happy about that. However, the same midwives did not change their performance in the clinical setting over these 7 months. There were no reduction in newborn deaths. There were no transfer of the new acquired skills into where it was needed in the real life. So we sat down with the midwives and asked what to do. And they said they needed to train more frequently within the real setting, not in the classroom. They needed to know that they were supported by their leaders. And everyone had to train, especially the senior midwives leading the culture in the ward. So we did what the midwives said. We created a training station within the labor ward for short but frequent trainings. And after only a couple of weeks, we saw changes in clinical behavior and improved performance in the delivery room. The change resulted in a 25% reduction in assumed fresh stillbirths and anywhere from 40 to 80% reduction in early newborn deaths, depending on the site. This was wonderful, but we still saw many unnecessary deaths. Babies who could have been saved with more timely and effective interventions. So together with midwives in Tanzania, the Safer Birth Simulation Center and Ladal Global Health in Stavanger, Norway, we began developing new innovative clinical tools, replacing those that had been used for a century. And here you see the Moyo fetal heart rate meter for easier fetal monitoring. This is the NeoBeat newborn heart rate meter for immediate and accurate newborn heart rate assessment. The new devices were developed in close collaboration with the midwives, addressing their needs. And they were tested in separate studies, which found that they were more effective than the existing solutions. However, innovations will not help anyone unless the providers know when to use them and how to best use them. So, alongside development of the new equipment, innovative simulators for practical training were developed, again in close collaboration with the midwives and what they needed. Here is a midwife at Hydom practicing newborn resuscitation skills using the novel upright resuscitator and the new neonatally live simulator. This simulator provides her automatic feedback on how she's doing. The midwives at Hydom did a lot of individual self-directed skill trainings, but they realized that this was not enough to improve clinical management of complex situations. So they started to create team scenario simulations, addressing shared situation awareness, communication, decision-making, and urgent actions. And here you see two of them training on a birth scenario using Mama Natalie, ending with a newborn resuscitation and a postpartum bleeding. Through an iterative co-creation period of around 10 years, we observed and studied more than 50,000 deliveries, mother-baby pairs, and learned what worked and not. In my opinion, innovations must be useful and effectful to be of any value, and we understood that to make an impact on lives saved, we had to put several of the different innovations together in a bundle. There is not one magic bullet who will really help a system. So this was the start of the Safer Births Bundle of Care program, and now I will show you a brief video of the program.
Safer Births Bundle of Care is a program to improve quality of care on the day of birth. It addresses the leading causes of maternal and newborn mortality with a bundle of clinical and training innovations. Use of data and regular simulation training enables continuous quality improvement. And strong ownership by the Ministry of Health ensures the program can be sustained over time. Safer Births is based on 12 years of research and collaboration, resulting in more than 100 published papers. If scaled up nationally in Tanzania, the Safer Births Bundle of Care could help save 25,000 more lives every year.
Thank you, you are too kind. We won an Innovation to Scale grant of $5 million from the Global Financing Facility, the World Bank, to scale up Safer Births Bundle of Care in 4 poor regions of Tanzania. So we have studied more than 300,000 births in 30 hospitals over 3 years. The program has been led by the Hydom Hospital in rural Tanzania in close collaboration with the Ministry of Health. And the main results was published by the prestigious New England Journal of Medicine last year. And this graph shows the combined monthly number of one-day newborn deaths over the study period. We used what is called a step wedge cluster randomized design. And you see how mortality is steadily decreasing as new regions, that's the vertical lines, starts implementation. Overall, a 40% reduction in newborn deaths was documented after start of implementation. But the really big surprise was related to maternal deaths. Overall, an absolute 75% reduction. And this impact was really driven by the innovative simulation training that was co-created and led by the midwives in each of the facilities. How was this possible? Together with the midwives, we adapted the Circle of Learning framework to serve as our implementation strategy for continuous quality improvement. The circle consists of 5 components that are building on each other, and I will now go through each of them. Starting at the top, healthcare quality improvement statistics. That was addressed by enabling easy access to own data. Data from ongoing training and clinical care were collected and shared back to the local facilitators and the manager in each of the 30 facilities. They used their own data to identify their own needs and to guide ongoing training, addressing their own needs. The next component is knowledge acquisition. All healthcare workers must have some basic theoretical knowledge, and that was addressed during the initial Safer Births trainings, and they were always aligned with the national guidelines in Tanzania. Then midwives must master several clinical skills, and skills proficiency was achieved through self-regulated individual skill training. And in this first phase of Safer Births Bundle of Care, the midwives have trained on average 2 times per week over a 2-year period. And here you see a typical skill training station. The midwives created a training corner in each of the 30 facilities where they could train in their labor ward whenever time allowed. The next component is facilitator-led simulations in teams. When providers manage all the different skills, they can train in teams, focusing on shared situation awareness, urgency, communication, actions. And in the first phase of Safer Births, they did 2 team simulations per month on average, and I think that is impressive when you know how understaffed most of these facilities are. And here you see midwives conducting a reflective debrief after a postpartum bleeding team simulation. The simulation and the debrief is facilitated by the local facilitator midwife, supporting psychological safety and reflection. We started the scale-up of the program by training 3 local simulation facilitators for each of the 30 hospitals. We followed the SimBegin facilitator training program to really give them the competence of being a facilitator. And these facilitators became fundamental in shifting from a culture of blame and shame to a culture of improvement and learning. And what you learn during training and simulation and debriefing must be translated into clinical care. That is where the impact is lying, on better, more lives saved because of better care. We have documented a strong, significant correlation between the number of conducted team simulations and the number of mothers saved. We don't find that same correlation between skill training and improved survival, but that does not mean that skill training is not important. It indicates that the components build on each other and that it seems that the circle of learning also represents a circle of increasing impact, driven by the competent midwife facilitator and mentorship. In the first phase of Safer Birth Bundle Care, we estimate that 1,000 extra lives were saved over a 2-year period, 600 babies and 400 mothers. Summarizing all the project costs, including the research costs, we ended up with $80 per life year gained, and that it's indicating that Safer Birth Bundle Care is a highly cost-effective intervention. So to summarize a bit, why were midwives able to save so many extra lives? They co-created the innovations addressing their own needs. They were involved from early planning through implementation. They were trained as facilitators to drive team simulation and culture change. They engaged in data-driven continuous quality improvement. They took part in mentorship and supportive supervisions. And there were systems for equipment maintenance and reprocessing that were established. So based on the very encouraging results from the first phase of Safer Birth Bundle Care, the program received an additional $8.5 million from the World Bank to scale up to all the 142 CMONC facilities in the same 5 regions, covering more than 600,000 births. Phase 2 ended in December 2025, and we are analyzing the main outcome data now. However, we have already looked at the number of trainings, and the midwives are really motivated to train, utilizing the bundle. On average, they have conducted individual skill trainings 4 times per week and team simulation training 3 to 4 times per week over this 2-year period, and I really think this is impressive. Around 1,000 lives were saved in the first phase of Safer Birth Bundle Care, and Tabu is one of them, and I will end with her story.
Globally, bleeding after birth is the leading cause of maternal death. The Safer Birth Bundle of Care is a program aimed at reducing newborn and maternal mortality. We are seeing remarkable results. A study published by the New England Journal of Medicine shows that after implementation of the Safer Birth Bundle of Care, maternal death can be reduced by an astounding 75%.
Kwa sababu tulikuwa tuna changamoto sana ya vifo vya mama na mtoto huko nyuma, lakini mradi ulivyoanza umekuwa ukifanya hizi simulation course, on job training. Kwa hiyo watumishi wameweza kupata hizo skills na wameweza kuwa confidence, wamekuwa competent. Sasa wanaweza kufanya hizi interventions za haya maeneo ya huduma ya mama na mtoto vizuri na kwa wakati.
Watu wa huduma tunaweza kufanya mazoezi ya pamoja kila wiki ili kujengeana uwezo na kuongeza ujasiri katika kuhudumia wamama wanaopata changamoto zitokanazo na uzazi. Na hili ni muhimu kwa sababu tunakutana na wateja wengi wanaopata changamoto zitokanazo na uzazi.
Healthcare workers who were trained using the Safer Birth Bundle of Care have been able to save more lives. Lives like Tabu's.
Alikuja kutoka zahanati kama PPH. Ametokwa na damu nyingi sana na walishindwa kutoa kondo la nyuma la senta. Bahati nzuri tulikuwa tumeshafanya mazoezi ya namna ya kutoa placenta ambayo imekwama, kwa hiyo tukawa tuna jinsi. Nilikuwa nafurahi sana kumwona mama yuko vizuri.
Kwa kweli nawashukuru akina dokta, mapokezi yao walionipokea, walinisaidia sana kwa huduma zao. Asanteni.
Thank you so much, our partners.
So, good morning. My name is Amy Weaver. I am the Chief Executive Officer of Direct Relief, and I am delighted to be moderating this next panel. So, Direct Relief is an NGO based in California, and we are the largest global provider of medicine in humanitarian settings around the world. Last year, we distributed more than $2 billion in medicine and other medical aid in more than 92 countries. Thank you. And we are particularly delighted to support midwives through our midwife and perinatal kits. So a year ago, I joined Direct Relief as CEO. Appropriately, I joined on May 5th, the International Day of the Midwife. And before Direct Relief, I had a very different background. I was president and chief financial officer of Salesforce, which is one of the world's largest technology companies. And in Silicon Valley, when we talked about innovation, it was almost always about artificial intelligence, arguing about prescriptive versus generative impact, or about quantum computing. Innovation was something that happened in an engineering lab. It was something that involved computers. But in the past year, I've learned that that is a very, very narrow view of innovation. And today, some of the most exciting, the most transformative, the most meaningful, and certainly the most life-saving innovation is coming from midwives. Midwives are our original innovators, and they have been recreating and innovating around childbirth for thousands of years. I have seen midwives in Ukraine training first responders on what to do when a woman goes into labor in a bomb shelter. We have seen our partners, Healthy Mothers, Healthy Babies in Hawaii, when they were unable to reach Maui by plane after the devastating fires, jump onto jet skis with midwife packs on their back to deliver materials. Hega beautifully showed how innovation is reducing maternal death dramatically in Tanzania. And at Direct Relief, we've seen what we can do by providing midwife kits. This is working alongside ICM, our incredible partners, and with midwives in conflict and humanitarian zones around the world to develop a new way of equipping midwives with the equipment that they need the most. And yes, technology is also being used in new ways to train and to connect midwives around the world. So today, there is no question that innovation is needed more than ever before. We are facing huge cuts in humanitarian aid. We are facing climate emergencies, shifting populations and immigration, and dramatic changes in healthcare networks. Luckily, I know that midwives, as the original innovators, are up for the changes and for the challenge. And today, I am so delighted to be joined by this incredible panel of women who are going to be talking about innovation in midwifery. So I'm going to ask each of you to introduce yourselves briefly, and then we'll jump in for the questions. So Anna, why don't I start with you?
Thank you so much. It's a pleasure to be here. I'm Anna. I'm the CEO of Maternity Foundation. We are an international NGO working in maternal and newborn health. And I would say almost everything we do is about midwives. It's about reaching and supporting midwives, especially in some of the more remote and fragile settings around the world.
Micah?
Good morning. I am Micah Daoud Elias. I'm a mom of 3 kids, Layan, my daughter, Joseph, and Majd, my boys, and Elias's wife, who I have to thank because he is now with the 3 kids, with the exams, and I ran here to Lisbon. So thank you, Elias. Second of all, I am a midwife. I work in a French hospital in Nazareth, and I'm originally from Haifa. I have a master's degree in women health and nursing. I'm also a lactation consultant. I wrote 2 books in Arabic, aiming Arabic women in the world about birth, preparation, pregnancy, and the other book is about menstrual cycle, so women can connect to themselves more. Alongside this all clinical work, I also have a platform on Instagram, and I am a content creator with more than 1 million followers all around the Arab world. I talk about pregnancy, women health, postpartum, and everything women need, because I know that many girls want to ask, but they are ashamed to ask. So this platform is for them to have reach every information they deserve to know. Thank you.
Thank you. Jennifer?
Thank you very much, Amy. My name is Jennifer Boating. I'm a Senior Program Officer for Maternal, Newborn, Child Nutrition and Health. It's a mouthful. At the Gates Foundation. I lead our midwifery portfolio, and I also sit across our product introduction team, overseeing the deployment of innovative maternal and newborn health products and drugs across lower and middle income countries. And I am also a midwife from Ghana. Thank you.
Well, good morning, everyone. On behalf of all of us, thank you for waking up early and being here. Part of me was a little worried we would just be sitting here talking to ourselves with everybody busy and having so much fun in the evening. So thank you for waking up to be with us. My name is Amber Wyseth, and my background is nursing. I lead a research and innovation program at Ariadne Labs. And Ariadne is a joint center between the School of Public Health at Harvard and Brigham and Women's Hospital. And whether I've been at the bedside or in administrative roles, in research, now also an entrepreneur, I've had the same North Star, which is my whole career has been focused on making childbirth safer and more respectful. So thank you.
So thank you to all of you. I told you it's a pretty incredible panel. So Anna, let's start with you. I am so excited about the Safe Delivery app and love our partnership. So that's become an important innovation in supporting continuing learning for midwives and for other health workers. How are midwives involved in the development, and what impact are you seeing from this?
Thank you so much. So Maternity Foundation, we started working in Ethiopia back in 2005. And we were doing, traditional community outreach, engaging with the community, engaging with the midwives, training, and so forth. But what sort of continuously, and we could have continued like that, replicating from district to district, from region to region. But there was really something about, we could continuously see, the knowledge was there, the evidence was there, but it didn't really translate into the actions on the ground. So we started to consider how we could use mobile technology to reach many more midwives with the available knowledge and guidance. To start exploring that opportunity, we gathered with groups of midwives in Ethiopia, in Kenya, and in Denmark, and to figure out what would be important in sort of boiling all this down into something that could work on a mobile phone. And that gave us a lot of sort of ideas to be tested. One of the key things that we learned already back then from Midwives was that we thought we were going to do still videos in the app, but it was clear that it had to be animations because that was much more intuitive, simple, and also respectful in a way. And I'm really, really happy about that today because that's the only way we've been able to continuously update, adapt, and change over time. Based on all this good feedback, we started a large randomized controlled trial. What we saw was over a 12-month period, a continuous and significant improvement in the knowledge, skills, and confidence among the midwives in the intervention group. We started off with emergency skills or areas. We also saw a significant reduction in newborn mortality. Another big research question we had back then, this is in 2014, so it's quite a few years back, was, can you actually use a phone? Does it work for this type of essential learning? And clearly it did. Midwives were quite tech savvy, so that was really good. Since then, we've really worked on getting this tool, free tool, out into the hands of as many as possible. It's a tool that works offline. Today, we have spread it to more than 500,000 midwives around the world. It's available in 5 global master versions and 30 nationally endorsed versions. And in quite a few countries, it has become sort of the go-to reference for access to guidelines, accreditation, and on-the-job support. We're talking about innovation. And sometimes, we think of innovation as this great gadget, technology, solution, or study. But innovation is really when the reality hits the ground. And in the reality, there's not, when you do an RCT, you sort of assume everything is equal. You assume there's commodities. You assume there is equipment, that there is, running water. But in the reality, that's not always how it is. So how can you build an innovation that works across different contexts and settings? And there I have 4 learnings that I think has been important for us. One is continue to listen and adapt to what midwives needs. And what midwives needs is not the same in each and every setting, so being able to adjust and adapt. Second, when you build something that you want to scale, you need to balance sort of this scalability, the global component, with your ability to localize. I sort of talk about, it has to be like a global model. For us, that has been, going back to the animations, that's been an important component. So this ability to sort of customize in terms of language, in terms of visuals, in terms of national guidelines, but even more importantly, being able to integrate and connect with what's already there, so you complement and support that. So this integration and handover, and not thinking about it as a project, but as a global good that you really just want to get out, is super important. Last, but not least, even in settings where there is no system to integrate with, or where there is no infrastructure or no system, we see a lot of uptake because midwives is taking it up. It's really about the champions and the leadership of disseminating and sharing, what works. So in Syria, in Afghanistan, we're actually seeing quite a big organic uptake, and it's really about these communities of practice who are taking this forward. And as we look ahead, we are really trying to build that community of practice into our future platform. So so just as a bottom line, innovation is about, leadership, it's about midwives, and then we can do what we can to complement with the tools and technologies that's out there.
It's wonderful, Anna. Thank you so much. So, Micah, I have to tell you, I am enjoying your Instagram posts so much. I've started following you. I do not speak a word of Arabic, and I'm still loving them.
Thank you.
And with more than 1 million followers, you've obviously made an incredible connection with your social media. This is a time where there's a lot of disinformation, there is stigma. How are you using social media to really drive trust and innovation?
I will take us all back at 2020 when I gave birth to my third child, Majd. And as you all know, after the first shower, after birth, we all know this event. And you know the uterus is empty, all the emotions are close to the surface, and I started to cry very hard. I started crying and everyone thought that I'm having some attack, but no, I just was thinking about women that are giving birth in crisis, in camps, women that don't have any support, any running water, and even though women that are giving birth in running water, maybe they don't have the knowledge, I didn't have the circumstances that I have. So I started to bless them and to pray for them. And after that, I thought that, wait, I'm a midwife, I have a voice, I speak the language. So that's what hit me to build this platform. Maybe I can't help a lot, but I can help a little bit just to give them the information they all need. When I opened the Instagram page, I decided to be in Arabic, in very simple language, like a big sister talking to their small sisters. And meanwhile, in social media, we can see that girls are scrolling all the time. They see very high standards for how to be beautiful, take this product to make the down there area pink, or smell like flowers, or I don't know what. It's like all the time telling girls that you are not enough as you are, you should fix yourself, you should hide yourself. And then I said, okay, I will be everywhere where girls are. If they're on Snapchat, I will be on Snapchat. If they're on TikTok, I will be in TikTok, because I don't want them to find me in the medical settings only. I will be in the middle, right next to the algorithm where they sell very high standards products and diet products. I started to receive messages from girls that they start to learn themselves and their bodies more. One girl said that you are like my big sister. You talk about things that my mother was ashamed to talk about it. Her smaller sister had a first period. She knew how to approach her because I talk about it a lot. Thank you. And then I had a story in the living room. One woman was with epidural, and I wanted to insert a catheter. You know, after giving epidural, you have to insert catheter. And I explained to her, and she was panicked, like, no, you are blocking the way out for the baby. And I say, Habibti, you have 3 openings. I draw her down their area, the urethra, the vagina, the rectum, and I say you have 3 openings. The baby has its own path. And the same day, I made a reel about it in Instagram, drawing down their area and explaining to them. And I was shocked, and how many girls are in Arabic world don't know even that they have these openings, and it's not in the same path. Also, I mean, how can we expect? I believe that if we want to change society or the world, we should change how babies are coming to this world. Because when a woman has a very empowering, when a woman have an empowering birth, she is empowered as a woman and as a mother, and then she had more to give to society, because each and every person is coming out of the woman's womb. So I don't know how we expect from women to be empowered when they are not empowered in their own body. So that's also I work in the social media. Also, there was a very known Arab doctor interviewing with a very big channel. And the interviewer asked him, what would you advise to your girls? To have a cesarean birth or vaginal birth? This was his answer. Would you prefer to ride a brand new Mercedes or a damaged old car? And he said, a brand new Mercedes. And then the doctor answered, that's why I advise my girls to have a cesarean section. And I think that there was my role to answer these doctors in front of millions of girls that are watching him, telling them that a body that gave birth and nourishing this fetus and creating this life, it's creating miracle, and it deserves to be talked about with respect and not comparing it to a car. Also, I have a daughter named Layan, which is my healer. And once she listened to me talking to a woman during birth, and I said to the woman, you should listen to the contraction. It's a language. They are trying to tell you something. And we were trying to talk, and then I hang out, and Layan told me, wow, Mom, we have incredible body. And I say, I made my work. I know that my girl is very connected to her body. And the thing that most was painful for me is that but girls are taught that menstrual cycle is something to be ashamed of. You should endure it. The blood is dirt. And I said, but each cycle is a chance for a girl to heal, to express herself, to have an intuition, to have a new beginnings each and every month. And this is our superpower. And if we teach girls to endure and not to love themselves, she is missing something very important in her life. So I think that a woman that understands herself, she creates, she leads, and she heals each and every month. So my deepest goal, thank you. My deepest goal is not just followers and beyond the context, is to raise a generation of girls that know who they matter. And I believe that every girl that know who she is, we can reduce domestic violence. We can encourage her to learn, to be more motivated to love herself. She will make better decisions in her life. So this is our goals as a midwife, to be there everywhere where they are. And how do I build a trust with the followers? I just show up. I show up everywhere they are. I use their language. I name things that no one are naming it. And I never shame them for not knowing. Because the shame is not theirs. The shame belongs to every system and platform that decided that women's body are too dangerous to discuss. So I'm just here to start the conversation. Thank you.
Micah, that was wonderful. Thank you. Just electric. So, Jennifer, it has been so much fun to get to know you this week and hear more about what you're doing at the Gates Foundation. The Gates Foundation has long invested in innovation and AI and technology and bringing that world to healthcare. And I'd really be interested to know, how are you combining those areas? How are you using those to strengthen midwives while at the same time focusing on clinical skills?
Thank you so much, Amy. First of all, I would like to simply state that at the Gates Foundation, we believe that every woman, every newborn, no matter where they are, deserves not to only live or survive, but to thrive. And at the core of the Gates Foundation work is the aspiration that no woman or newborn deserves to die out of childbirth. I would first talk about innovation by situating it in my own practice. I started my midwifery practice at my mother's clinic in a rural area in Ghana, My mother was a midwife in a remote village in Ghana where there was no electricity, there was no running water. And my first encounter with innovation is learning to hold a lamp for her while she was suturing, or learning to hold a lamp for her while she was undertaking a procedure. So midwives through the decade, my mother is 80 years old now, midwives through the decade have been innovators, and it is a big privilege to work in an organization that focuses on innovation. I would like to speak to a few of the innovations that midwives have been involved in over the years. At the peak of the HIV pandemic in Africa, midwives were at the front lines. Mothers who were exposed to the virus were able to receive good quality care because midwives took voluntary counseling and testing to the front lines. That was, digital tools, point-of-care testing devices that enabled midwives to identify HIV and to provide the services that women needed to them. Midwives have also been at the helm of affairs in the management of malaria. Rapid diagnostic testing tools have been used throughout Africa to identify pregnant women with malaria that exposes them to anemia and puts them at risk of postpartum hemorrhage. And I want to give a very big shout out to the midwives who were at the PPH mob. That was fantastic. PPH is the #1 killer of women during childbirth, and that is not acceptable. During the emotive trial, midwives were pivotal. It was sad to see that there wasn't a midwife amongst the principal investigators in that trial, but midwives were the champions. Midwives are innovating every day, and I want to also give a very big shout out to the midwives from low-resource settings who are not here, who unfortunately could not be here through no fault of theirs, but were prevented from being here because of immigration challenges. They are I learned about the word improvisation in clinical practice, because in low-resource settings, you have to improvise everything, every single thing. And that is where the Gates Foundation plays a role, because the need for innovation, the need for access is deeply inequitable. We at the Gates Foundation also stand with midwives in saying that the world needs 1 million more midwives. That need, Amy, is inequitable. Midwives are leaving lower middle-income countries in drones. They are leaving the places where they are needed the most to places that there is a need, but not as much. The Gates Foundation has supported the deployment of close to 10,000 midwives and designated skilled birth attendants to the places where they are needed the most through innovative co-financing systems that enables government to open up their fiscal spaces and give them opportunities to hire and retain them. These are the first points about innovation that I want to talk about. There are 2 domains that I want to focus on with my contribution to this conversation, and one is access. At the Gates Foundation, we believe, like I indicated earlier, that there needs to be equitable access. And I'm grateful to Heige for showing the numbers of women who are dying every day, and the numbers of newborns who will die. By the time we finish with this conversation, we can almost certainly guarantee that a woman in labor somewhere in the world right now would lose her life, and so will a newborn. So this is sad. The burden is deeply inequitable. There are so many midwives out there who are unable to provide the quality maternal and newborn service that is needed because they don't have the available tools to be able to deliver those services. There are places in the world today where a woman accesses service, but her blood pressure is not measured. Something as simple as that. In the places where anemia is endemic, women do not have their hemoglobin levels checked. Midwives have difficulty diagnosing preeclampsia, eclampsia. In these places, that is the #1 killer of women. For us to be unable to measure hemoglobin in an anemia endemic region is not right, because then we expose the woman to postpartum hemorrhage. And this is where the Gates Foundation comes in with point-of-care testing devices and tools, low cost, low skilled required, that enables midwives to reach women with these interventions and provide quality of care to them. So that is the first thing we do. The second innovation I want to talk about is risk stratification, risk assessment. I know that as midwives, we are highly interested in physiological birth. What we want to do is to ensure that women are receiving the right care at the right place and at the right time. So ensuring that we can risk stratify early using these points of care tools. So for example, an AI-enabled ultrasound reduces not just the cost of a bulky ultrasound that will cost the government hundreds of thousands of dollars. It will reduce it to maybe $2,000 or $3,000. It will reduce the skill required to train a midwife to deploy that innovation to the woman, and ensure that you can be able to obtain key parameters that enables the midwife to risk stratify the woman and assign her to the right pathway of care. Because not every woman needs a higher level of care. For so many of the lower middle income countries where we work in, that is critical, because some women are sometimes hundreds of miles away from the closest hospital or closest place where she can receive high dependency care. So that is highly important. The next thing I want to talk about is optimization of workflows. During one of my field visits, Amy, I entered an antenatal clinic, and I wanted to interact with the midwives there just to see how they are doing and how services are being provided. This was an antenatal clinic where the midwife was alone. And if I am not exaggerating here, there were close to 100 women at the antenatal clinic that day, and she was completely alone. I simply asked her, "How are you?" That was the only question I asked. And it led to about 5 minutes of crying. And it was difficult to see and to also know the reason why she was crying. She was crying because all her colleagues have left, and she's the only one left. That was her first reason. And it was sad to see that. But it was also sad to see that all these women had to be taken care of by one midwife who, by the 20th woman, would be completely exhausted. So AI tools enable midwives to optimize their workflows and to provide, to schedule visits such that they are able to provide the needed care within the most appropriate time. Thank you.
Jennifer, thank you so much. Those incredible stories. So Amber, first, I share your gratitude that so many people showed up on day 4 bright and early. That is very much appreciated. So Team Birth, your innovation, in some ways a relatively simple innovation, but it's having a huge impact on childbirth outcomes and the experience for women. So I love it because it shows that not all innovation is based on technology. So can you tell us more about it? How does Team Birth improve kind of interprofessional communication between midwives and obstetricians, and what are you seeing in terms of outcomes?
Great, thanks, Amy. For those of you that are not familiar with Team Birth, I'll just give a high level on what it is before talking more about how it improves communication and collaboration. But Team Birth was designed to be a very, very simple tool. So at Ariadne Labs, when we do new innovations, we purposely design for scale. So we're not designing just for that tool to work in Boston, where our office is, but we're designing it to work in birth centers all across the globe, in high-income countries and low-income settings. And so we spent an entire year designing this solution, and every time we had a prototype, we would come back together and say, okay, make it simpler again. But Team Birth was really created to help teams function better. And the very central person of the team is who? The woman, right? A lot of people get that wrong. Sometimes we get it wrong ourselves. But the team centers around the woman. She is the prime person. And babies are best not born alone. Whether it's the woman and a midwife as the team, it could be the woman, her support, the midwife, the family as the team, or in complex healthcare settings, it may also include obstetricians and specialists that are now a part of the team. And babies are best born within these strong teams. So Team Birth has a structure in how we talk, how we make decisions, and it's done both verbally and it's done written. And that written part is very important. As midwives, how many of you feel you're a good communicator? Quite a few, right? But communication is tricky. We may say the right words, we may have the right intent, but it's not always received how we intend. I think the best example for this is anybody married or have a partner? You never miscommunicate, right? Because you always say the perfect thing, right? We are humans, so communication at foundational level is flawed. So we need systems that will support so that our true intent is actually having the impact. So when we have this structured conversation with these 4 topics, who's on the team, what is the woman's preferences, what is the plan, like what are we doing, and when are we going to talk again, and that's done verbally and then written on a board on the wall, it ensures that we're all having the same understanding. So it's quite simple. Now, how does it impact teams? The first thing that it does is that it names every member of the team. Did any of you come with colleagues or teams? Yeah, there's a few of you who came at the party. When we're working in a team and we have roles in a team, that feels really good. And when we start with the team being the woman's name, and then her support, and then the midwife and anybody else included, everybody has been named and everybody has a role. And that is very empowering to people. So why we started with this was at Ariadne Labs, we first began with the creation of the surgical safety checklist. Many of you probably use that in your operating rooms across the globe. And we found in our research that if people introduce themselves, like, hi, I'm Amber, I'm the circulating nurse today, they were much more likely to speak up later on if they had a concern or there was a safety event. So being named on the team, yes, it's nice to know each other's names, but it's more about that invitation and permission to speak up. And so this small design structure is really meant to elevate the voice of the woman and to elevate the voice of the midwife. So that's one of the first ways. It really helps with interprofessional communication. The other, which we didn't actually design for, but we discovered along the way, as with many innovations are, you learn a lot as you go. It helps us to be accountable to each other when we have conversations and decisions all as a team. So when we were first studying team birth, I went to the hospital and I met with the night shift nurses. And I asked them how it was going. The night shift nurses were often quite young, and they told me they loved team birth so much. It was helping them so much. And I wasn't sure why it was helping the night shift more than the days, so I started to ask more questions. Well, in the model of team birth, all these decisions and conversations are happening at the bedside. So instead of calling a physician and having a phone conversation at 2 a.m., they were now having a conversation all as a team. Has anybody had a not so good nighttime conversation with a provider? Yeah? How would that conversation go differently if that was next to the patient in the bedside? Very different, right? Have any of you, as midwives, been short or snippy in the hallways with a provider or another fellow midwife? Has that ever happened to anybody? Are you going to confess that you've done that? Yeah. But does that happen when you're working with the patient and the woman? Less so, right? We hold ourselves more accountable when we're at the bedside. And so these are two sort of small ways in which this very, very, very simple design improves how we work in teams, both in naming each other and the opportunity and permission to speak up, but also in holding us accountable so that every interaction, every patient, every time is getting the best version of us as clinicians, as nurses, midwives, and doctors. And I could talk lots more about it, but I will make space for the rest of my colleagues in the next question. But thank you.
Amber, thank you. That was great. So what I think, one of the challenges with innovation is, this is not saying anything groundbreaking, but innovation is new. That means you've got to take time. You've got to take time to train someone on it. You've got to pull someone away from something else they're doing that's very important to show them how to take advantage of it. You've got to take someone who is already overworked and show them how this can help them and partner with them. So my question is, how do you balance taking sure that innovations are truly meeting the needs and not just making lives more challenging? And Jennifer, I was so struck by your story. I would love to hear from everyone on this, but starting with Jennifer, because I was so struck by your story of the midwife who had maybe 100 patients, who was so overworked. How can you use that technology, and how do you balance using her time when she's already so busy to learn something new?
Hopefully my response to this isn't a long one, because this is one of the areas where we have struggled with, particularly in resource constrained settings where the midwife's time is vital, and where women, are not receiving care if you pull the midwife out. In some of the places where we are rolling out the innovations, training is carried out in a way that midwives are pulled out into hotels, they converge in places for trainings to happen. What we are doing now is conducting training closer to where they are. Low dose, high frequency training, and optimizing training using AI. I want to use the AI-enabled ultrasound as an example. So this is ultrasound. We all know that ultrasound has to be delivered by, a sonographer, and that takes years of training. The AI-enabled ultrasound has cut down years to weeks, even though it has task shifted from, the sonographer to the midwife, but now the woman is receiving that service at the point of care. And the time that it would take for a midwife to have been trained to provide that additional service has been cut down by 90%. The cost has been reduced. The cost of procuring a device that important has been reduced. So these are some of the ways in which we are doing that. And I think Anna can also speak to how, training tools are coming closer to women with tools that, midwives is in a midwife's pocket. She can ask an AI tool for a question, and it would take her straight to, the policy guidelines, and she can make reference to it. So technology is making it easier to not only take services closer to women, it's making it easier for midwives to provide quality services, and for the training that is required to be reduced substantially.
That's perfect. Thank you, Jennifer. Anna, let's go to you on that.
Thank you. I think it's a good question, and I think there is a risk that it might happen that, midwives get overburdened with even more, things that needs to be registered or implemented or done in the everyday life. But I really think it should be the other way around. It should be what, should not be the midwives who needs to adapt to the technology, but the technology would need to adapt to the midwives. And I think there's a huge opportunity there actually to move, as you say, the service closer to the midwives. So for example, with the Safe Delivery app, what we have been able to do is to bring not only the guidelines, but also the accreditation and the learning into the hands of the everyday practice. And I think there's even, a convergence happening here with enabled by technologies, a convergence between training and day-to-day practice, a convergence between what is sometimes we talk about the last mile as this, thing far away, but it's the first mile. And I think we can use technology to bring the system and the support to the midwives in that. So that sort of convergence across the system and what is needed. And then I would say working with a free tool, we get brutal feedback. If this is not working, we can see that, because then we do not have the engagement among the midwives, right? So the feedback is right there. And then maybe just one last thing is I think it's also a matter of continually being able to just respond to what's needed. So, for example, we started with addressing emergency care, but then we could just, midwives asked us, can you please add, pregnancy, antenatal care? Can you add preconceptive care? Can you add modern contraception? We are now with direct relief and ICM, we're working to add a module on how to respond to, in terms of quality care in climate-affected areas, extreme heat, and so forth. So constantly listening and adapting, I think that's where it should start.
I love the concept of feedback. I have learned midwives are not shy. You will hear back with ideas.
Yeah.
So Amber, how does that fit with your world? How are you getting people to adopt and adapt to teen birth?
It's a great question. In our work in implementing teen birth, which has mostly to date been in US hospitals, so there's about 300 hospitals in the US, but also we've begun implementing in both Sweden, Switzerland, and then this year Nepal. Midwives tend to be some of the best champions. You all are known for being fierce advocates, and if outspoken, as you mentioned, they will tell you if they like it or they don't. But with teen birth, it tends to be well supported with midwives. But midwives are operating within a system. And so really to truly take on a systems change to provide completely different type of a care model, it actually requires the buy-in of everybody. And so when we do this, we are typically working very closely with women in the community, with midwives, with leaders, with administrators, to build the will, the champions within the facility to find those early adopters. In every system, there are going to be those that resist, and so we encourage the champions to keep moving and to keep building the will as they go. And midwives tend to be the best partners to do that. I think you all are natural innovators. Are you ever taking care of a woman and you don't have the material you need or the system you need or the product that you need? Does that ever happen? And do you just give up? Or do you build what in the US we call it a workaround. Is that term familiar? Yeah? You innovate all the time. And I guess I hope that you hear in all of us talking that you are positioned to be the best and the strongest innovators today and going forward. And I guess I hope to encourage you that when you catch yourself doing a workaround, and maybe you don't want anyone to notice because you don't want to get caught and then have to stop doing that, I want to encourage you to see that you have just innovated a better way of working. Innovators dream in solutions, and I encourage you all as midwives, I hope when you leave here and you go back to your settings, that you look for those moments where you're innovating and that you actually breathe those into life, that you elevate them and move them forward in the world, because you are the best to make change.
So Micah, you have such a unique view and vantage point on this, with 1 million people following you, giving you feedback, giving you ideas. How are you seeing innovation in this area, and how are you balancing that need?
I think that the loop feedback is everything. That when I post something, I read comments. I read what they want to hear, what topics they want to know, not just what I think that they want to hear. For example, there was a recent research that the egg is choosing the sperm. So then I chose not to post it, because I know in the Arab world, when a woman gave, it's not all, but if she has a girl, not a boy, they blame her, and we are trying to say that no, it's the sperm. So I decided not to post this research, because I know it will make more confused for her, because we are trying to save her from this. Second thing, I think that for us as a team, midwives, when women are coming to labor more confidently and more prepared, it also is our work, because you can connect with her easily and to build trust with her. But here is the challenge, that most Arab world midwifery is not enough improved. And we know, for example, I heard from a midwife from Palestine that they have 1 midwife for 10 women in labor. So this is very hard. They can't even connect. And obviously, the woman is getting from her experience very bad or negative experience. The midwife didn't approach me, but she's burned out. She can't reach you. So I think that we have two aspects. Also to help women to know themselves better, but also to improve the sector of midwife in the Arab world.
Wonderful, thank you. So a final question I want to ask each of you, maybe about a 1-minute response each would be perfect. Looking ahead, so what changes or developments do you see shaping the next generation of innovation in midwifery? And how can midwives be preparing to adapt? So Amber, I'm going to start with you, and we'll go straight down. So Amber?
Oh, shoot. I thought I had time to think.
I know, sorry.
Well, I think I gave probably my prime recommendation to you already, which was to, often we are our own barriers. You know, we think we're not a leader, or we have imposter syndrome. It's the same with innovation. Many of you feel you're not innovators. Maybe that term, that word, has not been something you've used to describe yourself. And so I hope that you actually leave here and say, I am a midwife, I am an innovator, and that you take on that role and that identity in solving these really important crises in our systems. But second to that, in innovation, it only happens through being good listeners, working in teams. And so I just hope that you all, yes, that you take your role as your midwifery and your education and your background, but women are coming into these systems, and Micah, you talked about this, but with so much noise prior to coming into the system with you, or prior to meeting you as a midwife. So I guess my encouragement is to educate yourself with what women are hearing. Follow Micah on TikTok so you can hear her content. But know that you are joining into an already established system and of belief and of knowledge, and it's your job to meet that woman where she's at and help move forward as a team.
Great, thank you. Jennifer.
From where I sit, I would say that AI is going to shift how innovation happens. And that is not going to be challenging, I think, in my personal opinion, because with the places where we deliver most of our work, access is a critical challenge. And what innovation in that space is going to do is to overcome that barrier. There are deep infrastructural and digital challenges, connectivity challenges in these areas. And AI is going to adapt and to ensure that women in these places are receiving the care. It is also going to ensure that midwives are able to receive tools at lower cost with lesser dependency on expertise. Even though we do not want midwives to lose their skills, midwives are not going to lose their skills. It is AI working alongside midwives. We are hoping that AI would bring care closer to women. There are social and societal norms that may stand in the way because most of the places where we work, women are not yet familiar with a lot of technology. But that is going to come down to their level, and the midwife is going to get closer to her through tools, very simple tools. She would be able to communicate with her midwife, and the midwife would actually know where she is, because some of these women are in places that are difficult to reach. So technology is going to bridge the access gap, and that is something that I'm really hoping would happen. Technology is going to make midwives better capable of delivering quality services to women. Technology is going to make sure the midwifery models of care can be delivered to women in low-resource setting. I forgot to mention about the intrapartum census. This is a very less cumbersome tool as compared to the fetal monitors that we are used to. A woman can move around easily with it. A midwife managing 10 women giving birth at the same time would be able to do it a lot easier because the tool will vibrate in her pocket while she's moving around if something is happening to a woman somewhere. So I believe that is where the future of innovation is going, particularly for women and midwives who are working in low-resource settings.
Well, thank you. Micah.
I just want to add something about the AI that once I delivered woman and we made different poses because the head was asynclete, and so made a lot of poses, and then she delivered and her husband told me, you did all right. And I say, how do you know? Are you a midwife or obstetrician? And he said, no, the AI told me what positions to do and you did that. I said, okay, good to have it. And I think that AI is a very good tool, but still it needs midwife because we as a midwife are the educators, are the advocates, and we know what women wants to hear from the AI. So I think, and the second thing is the next step is we have great researchers, great innovation, but I think that when women are in the dark, in the midnight, scrolling and afraid, we should translate all this information to be very accessible, simple to her, because not every woman are going to to medical sources and trying to search her answer. So I think to translate, to make it accessible more, and that's it. Thank you.
Thank you, Micah. Anna.
I think it's fair to say that we are living in challenging times at many levels. There's also a lot of defunding happening. And I think the times where we would roll out largely well-funded, sort of defined programs are changing. I think, so we need to think smarter and more cost-effective. I also think it's a good thing is that a change that is happening is that development is much more demand-driven and designed by the countries and by the users, such as the midwives. Obviously, AI can do a lot here, no doubt about it. So, for example, we are looking currently into how we can make our global good much more engaging, intelligent, based on each and every midwife's individual learning needs and context. So that's really, really exciting. What I think is very, very important when we think about AI in the future is that we need to always have not only a midwife in the loop, but also above the loop in terms of really, giving feedback in terms of what is needed and what is working. So midwives in and above the loop will be extremely important as we look at innovations in the future.
This has been a phenomenal, phenomenal panel. And a few of the things that I loved so much, Anna, you started off from your first comments using the word respect, that ultimately innovation is about increasing respect. You reminded us that innovation is when reality hits the ground, and that you have to balance scale with the ability to localize. And I also love the idea that it's not always midwives adapting to technology. Technology has to adapt to midwives. Wonderful. Meka, to start with, I think you have 3,000 new followers on Instagram. You immediately used the word sisterhood, which is being like a sister or a big sister. It's a word I've heard repeated every hour the entire week. It's been incredible. I also love the fact that you said you realized I have a voice. I have a voice. And I think that's true of everyone here. We have a voice. How do you use it? And when asked about how to get to garner trust, you said, I show up. And I think that is really a motto of every midwife. They show up. Jennifer, I loved the focus on access. And I love the fact that you said two things that sometimes people view as contradictory. One is you said, we need 1 million more midwives, and you also said we need AI. And too often, there's a view of AI only being used to replace workers. This was a recognition, Micah had it as well. Midwives aren't going anywhere. We need more. But AI and technology can be used to enhance what they're doing. And then Amber, I loved the idea of simplicity. Whatever we do, going back to simplicity, going back to communication. And you used the phrase, elevate the voice of the midwife, which really echoes everything else here. So there's no doubt in my mind that midwives are truly the original innovators, and such a delight to be here with all of you. And thank you very much, and thank you to ICM.